Hello, everyone. This is part two of the question set. We have a test question to start with. A 76-year-old woman sustained a low trauma hip fracture. She's prescribed calcium vitamin D and she also starts alendronic acid. What is the most common side effect of alendronic acid? Option A is that indigestion. Option B is it a rash. Option C is it nausea. Option D is it constipation. Option E is it headache. The simple answer is option A, which is why with alendronic acid, the instruction to take it upright with nothing to eat for 30 minutes is important, and it can also cause epigastric pain. The best answer is option A, indigestion. All the other options aren't really caused with alendronic acid. It's a pretty inert drug. Okay, question one then. A 27-year-old lady, she reports fatigue and frequent mouth ulcers, and she's now developed a rash on her cheeks, which is worse in sunlight. Which antibody is most likely to be present? We have A, ANCA, which is anti-neutrophilic cytoplasmic antibody. Option B, RF, which is rheumatoid factor. Option C, anti-CCP antibodies. Option D, dsDNA, which is double-stranded DNA. Option E is anti-nuclear antibodies. Pause for a bit, let you think about the question. Now it's obvious that the answer here is that the diagnosis is a case of lupus, and the picture at the bottom right shows you a classic malar rash with sparing of the nasolabial fold. So the antibody that is most present in lupus is actually E, ANA. It's far more commoner than double-stranded DNA, which occurs in about roughly 30% of cases, depending on the case series, 30 to 60% of cases. But most cases of lupus, at least 99.9% of cases of lupus will have a positive ANA. And there's a link for you at the bottom to watch a video there about understanding ANAs in the context of lupus. Question two is a 63-year-old man who presents with a 4-day history of severe headache of sudden onset. He also has transient visual loss in his left eye. He reports jaw cramping when chewing and has been feeling unwell for the last 3 weeks. Which is the most important diagnostic test for this gentleman? Option A, is it a CRP, C-reactive protein? Option B, is it a full blood count? Option C, is it a CT brain? Option D, is it an ECG? Option E, is that carotid Doppler studies? Now, the diagnosis in this case is a giant cell arteritis. And if it's a case of giant cell arteritis, the best option is A, because CRP, in almost always all cases of giant cell arteritis, isn't normal. It's abnormal. You get elevated CRP, and it can be a plasma viscosity or an ESR. So since the only inflammatory marker represented in this question is a CRP, the answer is a CRP. Question three, which of the following antihypertensives should be avoided in a case of Raynaud's phenomenon? You can see classic picture of Raynaud's. The answer is coming here quickly. That's fine. Of all the options, bisoprolol tends to worsen Raynaud's, so it's best avoided as much as possible. 61-year-old man presents with a 6-week history of pain in his shoulders and hip girdles that came on suddenly. There's marked morning stiffness but no weakness. Shoulder movements are globally restricted due to pain. What blood test would you expect in this case? So option A, would you get a raised creatinine kinase and raised CRP? Option B, would you get a normal creatinine kinase and raised CRP? Option C, would you get a normal creatinine kinase and normal CRP? Option D, would you get a positive rheumatoid factor and raised CRP? Option E, would you get a positive ANA and raised CRP? Now the answer, because the diagnosis is a polymyalgia rheumatica, the best answer is option B. This is clearly polymyalgia rheumatica, and you wouldn't expect any weakness in the muscles, and you wouldn't expect any issues with creatinine kinase, but you would expect a raised CRP. Increases in creatinine kinase suggest a muscle inflammatory disease, that's a myositis, but certainly not this case. Question 5, in which group of patients should a urine dipstick be considered essentially in assessing disease activity? So you have a sample of what urine dip schematic looks like. Option A is that ankylosing spondylitis. Is it B? Is it systemic lupus erythematosus? C? Is it Sjogren's syndrome? D? Is it dermatomyositis? E? Is it a reactive arthritis? The best answer here is B, lupus. Almost, not almost, but all lupus patients, I should say, all lupus patients need to have a urine dip at their clinic assessment, not just at first visit, but follow-up visits, because you want to be sure that there's no evidence of renal involvement. And renal involvement will often present with blood or protein, or blood and protein in the urine dip. So the presence of blood and protein suggests an active nephritic syndrome, and that would mean that the kidneys are under attack from lupus. So it's important that you have to do urine dip to ensure that renal involvement is excluded in all cases of lupus seen in clinic. Ankylosing spondylitis does not have renal involvement. Sjogren's does, but it's rare. That's not for you to worry about at this level. Dermatomyositis doesn't have kidney involvement, and reactive arthritis does not as well. So the best answer is lupus. Next question. What symptom is most likely in this lady? She reports a 12-year history of attacks of painful cold white fingers and 5 years of stiffening in her hands. Option A is a heartburn she's likely to complain about. B is it hemoptysis. C is it hematuria. D is it hair loss. E is it heat intolerance. You can see the tightness in her fingers, and she's talked about stiffening in her hands. This is a clear case of limited systemic sclerosis, and the commonest symptom they have is heartburn. It used to be formerly called CREST, and CREST is an acronym for calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. Now we just call it by limited systemic sclerosis when it's a limited type, or diffuse systemic sclerosis when it's the diffuse type. These patients do not get hemoptysis, do not get hematuria. Hair loss, very unusual, and heat intolerance is what you would likely get with thyrotoxicosis. Question 7, you see a patient who has recently been diagnosed with lung cancer. She has bilateral proximal weakness in her limbs and a photosensitive rash on the upper chest and neck. What's the most likely diagnosis here? Is it option A, lupus, option B, dermatomyositis, option C, polymyalgia rheumatica, option D, scleroderma, option E, polymyositis? The answer here is B. This is a V-neck sign, and this is seen in dermatomyositis. And dermatomyositis is a rheumatic disease that is often associated with cancer. The cancer can occur at the same time as the diagnosis. The cancer can occur several months to years after diagnosis. And sometimes you can get cancer, and along with the condition, as I mentioned, where the cancer, we regard the dermatomyositis along with the cancer as a paraneoplastic manifestation. Oftentimes, when you get the cancer and the dermatomyositis at the same time, treating the cancer often causes the dermatomyositis to get better, but sometimes you still have to treat the dermatomyositis. There are other signs you can get with a rash of dermatomyositis. You can get the shawl sign when it extends to the shoulders. You can get the holster sign when it's on the lateral aspect of the thigh. These are all those other signs you can get. And Gotchrum's papules, classically, you get it on the proximal interphalangeal joints, overlying the dorsum, the skin, and you can also get it across the metacarpophalangeal joints, the dorsal aspect of the skin in that regard. Question 8. This lady reports gritty eyes and Raynaud's phenomenon. Her oral mucosa appears dry. What is the most likely diagnosis? A, is it polymyositis? B, is it polymyalgia rheumatica? C, is it systemic lupus erythematosus? D, is it Sjogren's syndrome? E, is it scleroderma? Now you can see the dryness of the tongue. You can see how dry the tongue is. This is a clear case of Sjogren's syndrome. And what you see there is a geographic tongue. It looks like separate islands on the tongue. This is a geographic tongue seen in Sjogren's. And people with Sjogren's don't just get dryness in the mouth. They get dryness in the eyes. They get dryness pretty much in any area. Women can complain of vaginal dryness. And They can also have anal dryness. That's both men and women, which is important to take note of. Question 9. 80-year-old woman treated with for 6 months with polymyalgia rheumatica presents with a 36-hour history of severe headache. You suspect that this is giant cell arthritis. What other symptom is likely in this case? A, is it eye watering? B, is it a fever? C, is it muscle weakness? D, is it photophobia? E, is it vomiting? This case, classically, it's B. You would expect a low-grade fever. Of all the options, that's the best option. Low-grade fever can occur. Most patients would not notice, but typically these patients can get constitutional symptoms. They can be sweaty at night, and sweatiness at night is often that means that they're having fever. They get vasodilatation and they're sweating. They can get they don't tend to get weight loss. If you get weight loss, you need to evaluate with a total body CT scan. They do not get muscle weakness. They do not get photophobia. Vomiting is very unusual. Eye watering is most unusual. Last question. 21-year-old female student presents with a 6-day history of malaise, fever, weight loss, and a palpable purpuric rash on her legs. Her urinalysis shows a moderate amount of blood. Which of the following is the most important next test? Is it a CRP? Is it an ANCA, that's antineutrophic cytoplasmic antibody test? Is it an ANA, which is anti-nuclear antibodies, a blood culture, or a urine culture? Now, the fact that she has fever, she has weight loss, and a palpable purpuric rash with blood on a urine dip, you have to ensure that you do a blood culture. Very, very important, because fever, malaise, weight loss, even though she has a palpable purpuric rash, you should be doing an ANCA. You need to check that this lady does not have an infection first and foremost, mainly because it's a 6-day history of malaise, fever, and a palpable rash. Palpable rash. That's the key thing. Palpable rash. You want to ensure that there's no sepsis first. Although ANCA will be useful, you want to ensure that you get blood cultures done. Infection is far more common in this scenario than vasculitis. You don't want to get caught out. You want to ensure that you do blood cultures. ANCA would be useful, but the most important next test is to make sure there is no infection in this case.